Understanding the impact of social determinants of health on COVID-19 outcomes with Rama Rudraraju, Vivek Sanam, Gargi Amala, Ravi Kumar Kodapati.
Hi, this is Gargia. Please give me a minute while I share.
And feel free to continue chatting questions in the chat window.
Yes, this is Gargia, and I work with Vivek, Ravi, and Dr. Raju. Team 4 has also helped us, and we tried to understand the impact of social determinants of health on COVID. That's an outline. So we really wanted to focus on overlaying the county level social determinants of health and the COVID burden to see if there is any pattern or similarity and how they were reflecting. So this is based on previously existing work and definitely very recent work. The first one is by Kolak and et al., who quantified the neighborhood level social determinants of health within the continental US. And also the very recently published article, Disease and Healthcare Burden of COVID-19 in United States. So the social determinants of health paper by Kolak et al. Was focused on the socio-ecological model of health and social determinant indices. They primarily used 15 census data variables that are just listed here. They tried to understand how they can be grouped into some contextual indices, and they came up with 4 different principal components which would explain the complexity of the 15 variables. And these mostly fell in the outermost, the outermost sphere, which tries to get into the context, meaning the neighborhood, while they're also having an impact at an individual level. So this analysis was done at a census tract level, which is smaller than the county level, more granular. And they came up with 7 different types of census tracts. And you can see that majority of the US was considered as a rural affordable. However, given that we do not have COVID data at the census tract level, we had to redo the steps that they did with some improvisations, so we could come up with county clusters, so groups of counties that can be pulled together with similar social determinants of health. So this other work by Miller et al., they tried to focus and see how the counties might cope up with the COVID burden. So they used some simulation to explain if you can identify counties which are at or above the 90% quantile for hospitalizations per capita, meaning they're technically overburdened. They actually looked at an optimistic picture and also pessimistic and a combination of both. And they identified that it didn't matter if the COVID transmission was low, or it didn't matter if the COVID transmission was high. These are the counties that are colored in purple that could end up being overburdened with the COVID hospitalizations. So these 2 in the background, we try to understand at the county level what the social determinants of health could describe. So the data sets, and we did some clustering and some data visualization, and we'll list the tools as well. So we primarily used data from the 2018 American Community Survey, a 5-year estimate of variables which kind of replicated the work by Kolak et al. We had percentage population belonging to the racial minority, age distribution, disability within the county population, education, and English proficiency, percentage people living in poverty, what's the per capita income, the unemployment status, uninsured, and some housing-related parameters as well. And the COVID data was primarily used by Johns Hopkins by the majority of us. and I'll go over, give it over to Vivek to explain this part.
Hello all. So what we have done is we have used a package called UMAP. UMAP is nothing but a dimension reduction technique that can be used for visualization technique. It is similar to TSNE. Basically, TSNE and UMAP are nothing but non-linear dimension techniques. So this model UMAP is based on manifold with a fuzzy topological structure. So basically the cluster are found by searching for low dimension projections of each data that has closest possible equivalent fuzzy topological structures, and later stitch all those topological structures into single group so that we can understand the clusters in a better way. So we have given the census data to UMAP, that is on the left side. Then we looked at the clusters, but we didn't know what to name them. So later we have given the reduced data to k-means unsupervised clustering, and we looked at how many clusters it can form, and it did come up with something like 6 different clusters, and we have color coded them so that we can understand them in a better way. Can you go to the next? Yeah. Then we have, like, in 2D, it was little difficult for us to understand those clusters. So then later we have generated a 3D graph so that we can better understand those clusters and look at them. And then later, for the census data, we have added COVID data to see if there are any underlying patterns when we combine COVID data and census data. Similar to the previous process, over here, we have given, in the beginning, we have given it to the UMAP just to look at the clusters. Then the reduced data, we have given it to k-means clustering so that we can come up with clusters and later we can understand it in a better way. And this is the 3D graph of the COVID and census data combined.
All right. Thank you, Vivek. So for data cleaning, we basically use SAS, and that actually took almost the whole of first day because we had to download individual census tables and make sure that they're merged and work through. And then we used Python to run the UMAP and k-mean clustering, and Visual Code with TopoJSON, D3, JavaScript, HTML, all of this to finally visualize our results. To get into the results, we had a total of 3,140 counties with non-missing data, and looked like the cluster 5 had the most disadvantageous side of all the variables, and cluster 4 seemed to have more advantageous features. Like, I'll just pick on the per capita income being the least for cluster 5 and the highest for cluster 4. And once we focused on the COVID disease burden, looked like the cluster 5 actually had much better picture in the absolute numbers. But if we focus on the incidence rate, which is reflective of the population density as well, you see that the cluster 5 is performing badly. And though we didn't really see a clear distinct pattern within the other clusters, they do seem to fall in the spectrum between 4 and 5. So this is the map. Let me show. Right. So this is the visualization that was done based on the clustering. And on the left, we see that the counties are typed based upon the SDOH measures only. And we can see that the most disadvantageous counties are falling mostly in the southeast, and I'm not sure what we get out to that is Texas and Nevada, whereas the most advantageous are falling in the northeast and North Dakota. And on the right, we can see this is the cluster after instance. We're able to overlay the data from COVID as well. to identify and see how the incidence is. Should be pop-up bubbles showing incidence rate while we are seeing the underlying and
you have about less than a minute left to talk, and then we kind of move to questions.
Sure. So these are the counties that actually moved between the clusters from method 1 to method 2. So we are wanting to focus on these counties. And we do want to include time series data in future and reflect how the clusters might vary over time, starting from January, and conducting distancing measures to better fit the infectious disease dynamics. Any
Thanks.
questions?
Any questions? I'm just wondering what kind of challenges you had in combining those different kinds of data together, because often things don't match up. I know you were able to kind of merge them.
Sure. So I just had previous experience working with the census data, so I was aware of the troubles that I might run into. But the biggest challenge was we really wanted to include social distancing, and the data set we had like over 1,000 counties that were missing, and that was an unfortunate thing. So we really wish that we could get data for all the counties so we can better characterize how that might have affected these clusters.
What are your next steps or other challenges that you think you're going to face?
Yeah, the biggest challenge would be to visualize how the clusters might vary over time. Doing it dynamically might be challenging to visualize, even though it's easier to do in the background. And we really hope that we can bring in an infectious disease person to try to improvise the modeling techniques and make more sense